Dear professors and friends, my topic is factors associated with the pathway of genetic blockade in hypertrophic cardiomyopathy. Inherited cardiomyopathy is caused by pathogenic gene variation. In this lecture, we will discuss the genetic blockade techniques to prevent the transmission of the pathogenic variation to the offspring. We know that HCM is mainly a disease of sarcomere protein-related gene variations, and MYH7 and MYBPC3 are the most commonly affected proteins by variations causing HCM. Variations cause the phenocopies of HCM, including ATTR amyloidosis, should also be detected for the phenotype of ventricular hypertrophy for precise diagnosis. And the majority of HCM is are caused by monogenic variations and follow an autosomal dominant inheritance pattern. This patient population are the primary cohort to consuming a genetic blockade to have a healthy offspring. When we talk about the prevention of inheritary cardiomyopathy, usually we mean the secondary prevention and primary prevention. For the secondary prevention, it was performed during pregnancy, which is a prenatal diagnosis. The fetus DNA was obtained and gene test was detected. If high-risk genotypes were detected, some families may consider termination of pregnancy. We must note which this technique may cause ethical controversies and injury of the emotion and the mother. So it's not a perfect technique. And then primary prevention, which is performed pre-pregnancy, which can completely block the transmission of the pathogenic variation to offspring, may be a better choice for these patients. The technique is called pre-implantation genetic testing, abbreviated as PGT. The majority patients of have HCM is autosomal dominant inheritance pattern. This is the theoretical basis of the genetic blockade. Look at this picture. If the mother is affected by a pathogenic variation and the father is unaffected, then the offspring, regardless of the gender, each offspring has a 50% chance of get the pathogenic variation. So this is the basis of the PGT procedure. And this slide shows the procedure of PGT for monogenic inherited cardiomyopathy. Under usual circumstances, female will ovulate one egg every month. But for PGT, the ovulation induction is the first step to get multiple eggs, and then sperm and eggs were collected, and in vitro fertilization were performed, and then cultured. When the fertilized egg was cultured into a blastocyst stage, and one single cell was biopsied, and do the genetic test to choose high-quality blastocysts that are identified as not carrying the pathogenic variant, and select the health blastocysts to transfer to the uterine, and thus to bring have a health offspring. And there are three must consider elements for PGT procedure. The first one is genetic diagnosis and screening. Only the variations of pathogenic or likely pathogenic could be used for PGT. And next, if the patient is the female one, then the heart risk must be evaluated before developing the reproductive plan. Is there any treatment should be performed before the pregnancy? And after the treatment, what's the risk stratification of the female HCM patient's heart? And so we need a multidisciplinary team to consultation and develop the plan of reproductive and the heart treatment and the follow-up plan. As each patient of HCM has her own unique clinical profile, so for most of the patients, we develop a tailored plan for specifically for each patient. Now I will share two patients in our center. The first one is a female of 25 years old. She has obstructive hypertrophic cardiomyopathy. And she has no history of atrial fibrillation and no ventricular tachycardia. UCG shows that the left ventricular ejection fraction is normal, and the left ventricular outflow tract obstruction and the pressure gradient is more than 80 millimeter of mercury. And now let's look at the three must consider elements for PGT procedure. The first is genetic diagnosis. This patient, the genetic test found a pathogenic variation of MYH7 gene. And then we do the risk assessment of this patient. How much, what's the risk during the pregnancy and the perinatal period. According to, it was reported that HCM can significantly increase the risk of sudden cardiac death, arrhythmias, and heart failure. And pregnancy-related cardiovascular changes may exacerbate these risks. And so what is the accuracy rate of the adverse events during these special periods? According to modified WHO criteria, obstructive HCM is classified into class 4 pregnant, which means the maternal mortality rate increases significantly, or maternal and fetal complications increase severely. Expert consultation is required, and multidisciplinary collaboration and close monitoring during pregnancy and the perinatal period are necessary. And this consensus was published in 2016. And this study was published in 2017. In this study, about 23% of the patients with HCM experienced at least 1 miss during pregnancy and postpartum. It's very high. And in 2022, a systemic review was published, and the study results shows the complications during the pregnant and perinatal is not as high as the study previous in 2017. And this picture shows a study published several months ago this year. It included more than 10,000 women with a history of HCM and was divided into two groups according whether they have a history of pregnancy or not pregnancy. The follow-up time is about 10 years. And the primary endpoint is all-cause mortality. Secondary endpoints include arrhythmic events and MACE. And we can see for the right picture, we see that during a 10-year follow-up period, pregnancy did not increase the risk of adverse events in patients with HCM. These are we look for the some literatures to find some evidence to make a plan of our patients. We see that during the with the time advancing, the complication rate decreasing with the time. So I think maybe it's attributed to the development improvement of the follow-up and the preventive treatment. Our patient is an obstructive HCM patient. So let's look at the subgroup analysis. The subgroup analysis of all HCM showed no difference in the risk of MACE, all-cause mortality, and arrhythmic events between the two groups during the 10-year follow-up period. And these are guidelines and expert consensuses related to assessment of pregnancy and childbirth risks and cardiac management during pregnancy and the perinatal period. And the multidisciplinary team made a comprehensive plan for the patient, including protocol for heart failure. Now, before pregnancy, the patient has a normal heart function, but heart failure might occur during pregnancy. If it occurs, what medication we can use and what we can't use, what medications are contraindicated, and also if necessary, we can do catheter ablation to relieve left ventricular outflow tract obstruction, and the procedure can be guided with intracardiac echocardiography, so to avoid the harm of radiation on the fetus. Also, we made protocols for the possible of arrhythmia, including atrial fibrillation and ventricular tachycardia. And if the arrhythmia is with unstable hemodynamic, cardioversion can be performed. And if the stable hemodynamic is stable, we can use some medications. And also during pregnancy, if necessary, catheter ablation could be performed with eyes guided, but it's usually we don't do that. After the fetus transfer, the patient was followed up in both departments of cardiology and obstetrics. The patient has a stable clinical condition throughout the period. Now I will share the second case in our center. This patient is also has a hypertrophic cardiomyopathy, but she is 37 years old and also has many clinical symptoms, dyspnea on exertion and syncope history, and sustained atrial fibrillation and severe obstruction and increased pro-BNP level. The genetic test found the MYH7 pathogenic variation. This patient is quite different with the previous one because she needs treatment before pregnancy. includes the catheter ablation for atrial fibrillation and septal reduction therapy because CMI is contraindicated during pregnancy. And SD is necessary for her, and anticoagulation drugs because she has sustained atrial fibrillation. So the medical team discussed with the patient and the family completely with the risk, the heart risk during pregnancy and perinatal period, and we together we discussed the treatment and the protocols to treat the possible complications during the pregnancy. And because the patient is already 37 years old, after we complete the treatment of her heart symptoms, after we use radiation to mask the weight for 6 months to have the egg collection. So we made tailored specific protocol for her. And after MDT consultation and the gene test, the reproductive center do the egg collection first, and then reproductive center do these IVF and culture and single cell sequencing, and choose which one is the best one. During this period, we cardiology center do the treatment of cardiomyopathy. So radiation, surgery, anesthesia, and medications will not harm the quality of the egg. And then after the patient recovered from the treatment of the from the cardiology department, and the reproductive center have already prepared the best blast cyst and then transfer. And then the patient was followed up in both cardiology and obstetrics department, and then get a healthy girl. And we know that some patients, some HCM patients, was caused by mitochondrial DNA variation. Then how to do genetic blockade for these patients? We know that inheritance patterns of mitochondrial DNA variation disease is the maternal inheritance. For everyone, our mitochondrial DNA comes from our mother completely, not from father. This is a theoretical basis for this kind of patient, the blockade, genetic blockade. This patient is not from our center. It was published in New England Journal of Medicine this year, several months ago. These cases are from England. The procedure is called pronuclear transfer, PNT. The embryo his DNA from his father's DNA and biological mother gives him the nuclear DNA, and the donor mother gives him the mitochondrial DNA. So to combine a healthy embryo and then transfer to the uterine to get a healthy offspring, to block the transfer of mitochondrial DNA variation cause the HCM. And future directions, and there are some challenges, such as if a patient, the genetic test found a VOS variation, and some patient is there, some in some country or some there are ethics regulations, so it's a very far way to go. Thank you.